Welcome to this virtual roundtable, where we will be discussing some of the key data that emerged from this year's ASCO meeting. I'm Hope Brugo, Professor of Medicine and Director of Breast Oncology and Clinical Trials Education at the University of California, San Francisco's Comprehensive Cancer Center. Today, I'm joined by three expert leaders in their fields: Dr. Sarah Taleni, a breast oncologist at Dana-Farber Cancer Institute; Dr. Jack West, a thoracic oncology specialist from City of Hope; and Dr. Shilpa Gupta, a genitourinary oncologist from the Cleveland Clinic. I have Dr. Shilpa Gupta, who's an oncologist from the Cleveland Clinic focusing on GU oncology, who's going to talk to us a little bit about some of the most interesting data from ASCO 2020 in GU cancer. So thank you for being here and talking about this area.
Thank you. My pleasure to be here.
Great. Well, so let's jump right in and talk about some of the data that we have. In bladder cancer, there was an interesting trial, Javelin Bladder100, looking at maintenance of avelumab and best supportive care versus best supportive care alone in patients with advanced urothelial carcinoma. An interim analysis of a phase 3 trial with some really, I think, quite practice impactful data. Can you tell us a little bit about that study design and the results?
Yeah, sure. So this was a phase 3 randomized trial of patients who received first-line platinum-based chemotherapy with either cisplatin or carboplatin backbones, and patients who did not progress after the first-line therapy, that is those with stable disease, partial response or complete responses, they were randomized to receive avelumab every 2 weeks versus best supportive care as a maintenance therapy. And the primary endpoint was overall survival. And this study showed that the overall survival was significantly improved with patients who received avelumab compared to best supportive care. And it was 21.4 months in patients who received avelumab compared to 14.3 months with best supportive care. And this is the first study that has ever shown overall survival improvement in metastatic disease as a maintenance treatment. So this is very exciting data.
It sounds very exciting. I think that's just a huge difference in overall survival, almost a doubling in overall survival. One, of course, great interest for all of us with checkpoint inhibitors, it was whether this was confined to patients who had PD-L1 positive disease, or was it all patients?
This was in all comers, although they showed that in the subset of patients with PD-L1 positive disease, the overall survival benefit was better. Like it was 17 months in the best supportive care arm versus not reached in the avelumab arm. And one thing to note is that the majority of the sites for this study were outside of the US. So a lot of patients don't have routine access to immunotherapies. But the authors showed that around 50% patients went on to receive subsequent immunotherapy as standard of care.
That's really interesting. So even with the ability to receive in half of the patients checkpoint inhibitors later as later line therapy, it still had a big impact on overall survival. So is this something that you would do now? You were previously giving patients with advanced urothelial cancer not on trials platinum-based first-line chemotherapy. Would you now routinely add avelumab to this treatment? And are there any concerns you have about doing that?
No, we would add that as the study population, that if patients have a response or stable disease to platinum chemotherapy, then yes, based on this level 1 evidence, once approved, we would add it as standard of care. Right now, we were not doing it outside of a clinical trial. There was another clinical trial we participated in through Hoosier Network, which used pembrolizumab compared to placebo in this similar setting. And that also showed progression-free survival benefits. So clearly, maintenance immunotherapy in first-line setting seems to be paradigm shifting in metastatic disease. So once approved, we will start offering it.
That's really interesting. What a really it's an amazing set of data in patients with urothelial cancer. There was another really interesting trial in patients with early stage, high risk muscle invasive urothelial carcinoma, IMvigor010, that looked at adjuvant immunotherapy versus observation. Can you tell us a little bit about that trial as well?
Yeah, so that was a phase 3 randomized trial of adjuvant atezolizumab versus observation in patients with high-risk muscle-invasive urothelial cancer. Patients with node-positive disease were enrolled in that. However, positive margins were not allowed. There are around 800 patients enrolled, and the primary endpoint was disease-free survival. And unfortunately, did not meet the primary endpoint. And that is disappointing, but it's also a huge learning curve, as this is the first adjuvant immunotherapy trial data that we have.
Do you think that there would be a different way to look at checkpoint inhibitors in early stage setting? For example, do these patients receive chemotherapy regularly, or would you maybe treat the patients with some combination of chemo and checkpoint inhibitor therapy?
Yeah, so currently as standard of care, we routinely don't offer adjuvant chemotherapy unless patients have really significant disease at cystectomy or despite neoadjuvant chemotherapy, because we know that patients, if they did not respond to cisplatin, then adjuvant platinum won't really help much. So we sometimes add taxanes as adjuvant therapy, but there's really no clear-cut survival data so far. So these immunotherapy options were very attractive, and but now that this trial is a negative trial, we are thinking whether moving it even early on is more beneficial, like in the neoadjuvant setting or in the first-line maintenance setting, which is not before this, but once patients have become metastatic. We saw in the Javelin 100 trial that immunotherapy is beneficial, but it almost makes one wonder if some disease is needed before immunotherapy is effective in bladder cancer.
No, that's a really interesting point. There's been a lot of discussion about that you need some disease for the immune system to be trained against, maybe, although you figure that a lot of these people have microscopic disease. That's why they have a high risk of recurrence. But the chemo with neoadjuvant therapy is quite intriguing, and certainly in my specialty in breast cancer has been of great interest with immunotherapy. There was a trial looking at, in some ways, a neoadjuvant type response, SWOG S1605, that looked at atezolizumab in BCG unresponsive, non-muscle invasive bladder cancer. What did that trial show?
So that trial is again a different setting in bladder cancer. That's non-muscle invasive bladder cancer, where traditionally BCG immunotherapy has been used for decades. But for patients who are BCG unresponsive, ultimately the standard of care is radical cystectomy, which has been the gold standard for all these years. This trial looked at atezolizumab in BCG unresponsive disease as a means for bladder preservation. And interestingly, in this SWOG trial, the primary endpoint was complete response at 6 months, and the FDA mandated a biopsy to confirm that there is no CIS or carcinoma in situ present. And this trial did not meet that endpoint, but they found that the 3-month complete response rate was quite similar. It was 41% in this trial, and it was quite similar to another trial that tested pembrolizumab in this similar setting, leading to FDA approval earlier this year. But that was the secondary endpoint in this. So while the primary endpoint was not met, if we go by the endpoint that was accepted for pembrolizumab, which led to its approval in this setting, that was comparable. So it's really crucial now that looks like immunotherapy is active in this setting after BCG failure or BCG unresponsive disease. But the key is to see what the long-term follow-up data shows in terms of durability of responses, because even with the other approved agent, pembrolizumab, the CR rates tend to drop with time. So one really needs to know how much are we benefiting the patients when radical cystectomy can be potentially curative. So long-term follow-up data will be crucial from that. But to your point, that adjuvant trial was negative, but these trials in other settings in bladder cancer are showing a lot of promise.
It's really interesting, the idea that longer wouldn't be better, that you get more benefit from chemotherapy, presumably with more exposure. It's not really clear why it would be. These were single agent checkpoint inhibitor therapy in this trial. And I wonder, if maybe the tumors become more resistant to immune therapy over time. It doesn't totally make sense that you would have less rates at 6 months, but
Yes,
maybe if you
that's
did
a great point. And I think one of the issues that a lot of people wonder about is that, in this trial, there was a mandatory biopsy, but in some other trials, for example, the pembrolizumab trial, there was no mandatory biopsy. And the CIS is notorious for being sneaky, and you can miss it often just by a cystoscopy. So that's why I think the key is to have similar endpoints in all these trials. If a mandatory biopsy is what we need, then that's what we should do for all the trials. So I think now FDA has a consensus statement, and it's important to have that endpoint. But I've heard from a lot of urologists that not doing the biopsy can sometimes miss the CIS, and it's possible that's what happened with the pembrolizumab trial.
So would you treat, which kind of patient would you give neoadjuvant pembro if it's approved now for BCG resistant disease?
I think it's a lot of it is driven by what patients want. As you know, a lot of patients, in fact, most patients don't really want to go for cystectomy. They want bladder preservation as their option, especially when they know that if it doesn't work, then they could always get cystectomy later. There's always the risk of disease progression, but I think, when we had this trial open, patients were willing to go on as long as, they got to keep their bladder. So, but it's also a decision we make in our multidisciplinary setting with the urologist, because a lot of urologists are not convinced with the immunotherapy data in this setting, and they believe that cystectomy is what should be offered. So I think it's really a team decision along with patients' wishes that we are utilizing here.
So it sounds like all of the different areas in cancer now, that we're really individualizing more and more for the individual patient situations. But the point that you made about trying to harmonize endpoints and harmonize the way we treat patients is so important. I really appreciate your perspectives and this great overview of 3 really important trials in the management of urothelial cancers. Thanks again.
Thank you so much for your time.